taking time off on a Saturday and trying to learn something in this lockdown period. So, to cut it short, it is beyond the scope of it is beyond the scope of try and the entire gist of what we can achieve by addressing the term cognitive rehabilitation. What I'm going to try and do is try and create a picture and leave you guys thinking that why is it important for us to have this specialty area as a necessary and vital tool, especially for neurophysios. So to start off with, the main concern is, why are we so worried about cognitive deficits? So in a nutshell, basically cognitive deficits are invisible barriers. They tend to be what we call as hidden disability. And more importantly, these problems will persist if they are not acknowledged, not dealt with, not treated with. And eventually in the long term, when you're looking at community rehab, not only just from a neuro perspective, but other areas of physiotherapy as well, you're basically stuck up in a vicious cycle wherein the patient is able to return to normal life, normal work. So hence the importance of trying to at least pick up what can a cognitive impairment lead to, and then hopefully, if you're trained and if you have the necessary beyond the scope of this webinar in half an hour to try and explain or bring about why is it important for us to address cognitive deficits as physio. However, having said that, it is a vital tool, and I would say absolutely necessary, especially as neurophysios, to try and have a good understanding of why you need to address cognitive impairments and then look at necessary steps to address them, deal them, and intervene them. So, why are we so concerned of cognitive deficits? As we can all imagine, these tend to be invisible barriers. So you cannot see what cognitive impairments a person comes across with, unlike other areas of our expertise in MSK, cardio. You have a particular dysfunction, you see that visibly. But with cognitive impairments, they are sort of hidden disabilities. So very important for us to pick up those hidden disabilities and address them. And more importantly, the problem and the main issue here is, unless they are dealt with and addressed, they tend to persist. And eventually, as a physio, you tend to work on trying to achieve a particular goal. However, if there are strong elements of cognitive impairments, you tend to be sort of stuck up and try and figure out as to what else can you do to try and have some successful rehab for that person. And at times, the solution is sort of quite simple, that you haven't addressed the cognitive elements.
Please mute yourself, please.
I think the key message here for all sort of clinicians here is, and especially physios in particular, is that the terms action and cognition, they go hand in hand. So for us to able to achieve a particular movement sequence, a particular movement pattern, a particular rehab goal, you need to make sure that there is that level of cognition present, so that the patient is able to understand that and achieve maximum sort of independence, maximum outcome of our rehab. Unless the two are addressed together, you're going to find a gap between the two. So very important to address those cognitive deficits and then deal with them appropriately. Now, at a very basic level, very important for us to understand that the four main cognitive domains are attention and concentration, when we see a particular activity or a particular person, we recognize that person. When we meet that person again and again, we then store it in our memories. and eventually we execute them. But a person with any form of neurological insult, brain injuries, take a spinal cord injuries, high levels, there tends to be some amount of impairment in either each of those domains individually, separately, or as a combination. Now, the nature of the human brain is such, and to make it a bit more precise here, fortunately and unfortunately, all these basic cognitive domains are linked together. So if there is a problem at one particular element of this cognitive domain, it is going to have a knockdown effect on the other domain at the same time. So it's important that even though one of those elements is absolutely fine and perfect, we need to then retune and refine it to make sure all of them work in harmony. Otherwise, you're going to have some sort of dissociations and not be able to achieve maximum sort of outcome for your patients. Now, there is sort of strong evidence, and it is quite obvious that the three main domains under which we tend to address cognitive impairments, like spinal cord injury clients, and any form of neurological insult to the brain. So you name it, stroke, multiple sclerosis, Parkinson's, and so on and so forth. So each of them will have some amount of cognitive impairments related to the overall impact of the injury. At a very basic level, what you're trying to achieve here is trying to map up our internal sort of impairments and see what can be achieved externally. So 8 out of 10, especially neurologically, cognitively impaired ones, will have a mismatch between the internal and the external reality. So what you see is different from what is expected. And to bring it in a nutshell more precisely, any form of neurological insult will just not have a basic sort of either sensory or motor impairment as we come across, say, for example, sparsity or deficient sensations. But along with those areas up in the map, you have your different lobes, frontal, parietal, temporal, occipital, and they all have important cognitive elements associated with that. So we have to understand that it is not just restricted to having an improper movement pattern related to spasticity or weakness or sensory deficits, but equally important that they have an element of cognitive domain associated with that. Sorry, I'm just trying to. Right, can you all still see my slides up there?
No, sir.
Can you see my slides now?
Yes, yes, sir.
Yes, sir.
Yes, sir.
Yeah, we are able to see.
Okay. Now, like I said, it is beyond this scope of a 30-minute presentation to address everything in terms of assessment, treatment strategies, and sort of complete cognitive rehab. But to bring across an important element here as clinicians, you want to make sure you understand and you have a good understanding of what your patient's own cognitive abilities are. So following a neurological insult, you want to map out, is there an element of memory which is problematic? Is there an element of information processing which is problematic? Or is there an element of wider functions, or executive functions or information processing which is impaired? Now, how do you do this? There are specialized battery of tests which our colleagues of the MDT specialized and neuropsychologists are excellent at. So this is where we need to step in, ask for the help, get a good thorough assessment of those important cognitive domains, which will then eventually help us for a proper rehab. Once you've mapped out what those cognitive impairments are, you are then looking at, is there an ability within the patient to either make those necessary changes in a new way, or can existing skills of those patients still be used to then bring out the efficient outcome for him. And these two terms, self-awareness and self-regulation, are quite important in planning for a rehab, especially after a neurological insult with major cognitive impairments. Now, if the impairments are between the mild and moderate, 9 out of 10 patients will have a good self-regulation. So they will understand with repeated principles of neuroplasticity, use it, motor relearning, and they'll be able to regain the pre-injury independence. However, if the category starts between moderate to severe, both the self-awareness and the self-regulation will be jeopardized. So you're going to have a tough time trying to now sort of look out at alternative ways to find out how this can be achieved for those patients. Just to highlight and reiterate the previous sort of point that I mentioned, your ability as a therapist, as a clinician, to develop appropriate awareness within that patient is going to make the most important part of your rehab journey, especially if you're dealing with patients with traumatic brain injury. For them, as well as their families, it is a complete shock. And as you go into details of what particular elements of the brain are affected, there can be elements of, simple stuff as apraxia. However, if the injuries are between moderate to severe and there's a lot of sort of neurological insult, imagine a person losing out on speech. Imagine a person losing out on what we call spatial awareness. So this complex sort of cognitive impairments tend to start making the picture a bit more complex. They start making things more complicated for rehab, and often we as physios tend to focus on the eventual outcome of mobility, which is correct. We want to make sure the patient is back mobilizing to pre-independent levels and back in the society. But for various reasons, in terms of maybe lack of time, lack of awareness, or lack of resources, this particular element is sort of missing. And unless you try and develop a culture and a pattern of starting to recognize cognitive impairments, number one, things will not only be much more easier for you from a rehab perspective, but you're going to achieve more sort of successful outcomes with complex neuro clients. Because a simple example of a stroke patient, if the injury is between mild and moderate, you're expecting some sort of compensated movement patterns, and you're doing a repetitive process of motor relearning. However, if in the background there's an element of cognitive impairment, say for example at the basic level of the person not being able to process information, you do the hard work of a 40-minute session teaching a particular exercise or movement pattern. The patient at that point of time will follow your instructions, get it done, because what he's doing is what we call a motor mirror learning. He sees you, he copies you, and he learns it. However, the carryover effect when they go back home is poor, because they've not been able to process the information. So the next session you see him and you try and repeat the same movement sequence, the patient has no clue, because he's not been able to process the information. And if the information is not processed, it will not be stored in the memory. So you get a bit frustrated saying, I spent 40 minutes teaching a new movement pattern, a new exercise, and the patient has, just forgotten it in 2 days. And there starts the vicious circle. You try and teach that again. The patient goes home, forgets it again. So very important for us to recognize that, hold on, the key element of rehabilitation here is not for me to make more repetitions, but to make sure the person has processed information. And that could be, depending on that person's level of intelligence, a simple thing: you draw a diagram and explain to it. The person takes it home, or with the technology advancement now, you do what we call a video shoot and give the person to go home and see. So it is then that with repetition of that particular element which is lacking, the person starts processing information and stores it as a long-term memory for it to be executed. So the key message here for the rehabilitation update is your internal map must either be redrawn or modified to match the external reality. And this comes with a lot of practice and a lot of sort of joint team effort work. In a nutshell, when you're addressing especially neurological clients, the main aim of cognitive rehab therapy should be to improve the ability to carry out everyday tasks. That's it. That is a key message. The main aim of cognitive rehab, you have to focus on everyday tasks of that person. Key issues for us to address here, like I mentioned earlier, get into a habit, a culture, a pattern of recognizing cognitive impairments. And once you recognize those, use the resources. You have the skills of an occupational therapist who are very good in doing specialized neurological tests from a rehab perspective. And if the injuries are severe, traumatic brain injuries, traumatic spinal cord injuries, and other complex neurological insults, use the services of, they have an in-depth assessment. And when you get the results of those assessments, you're in a better position to then able to plan your rehab goals accordingly. And I think as responsible clinicians, we have to make sure we sort of try and overcome the stigmatic concerns associated with this. And this is just not a concern up in developing countries, but also in developed countries. The moment the terms neuropsychology or neuropsychiatry step in, it tends to be a stigmatic approach that there is something wrong. Yes, there's something wrong. These are basic elements of mental health. As a normal person, we face periods of anxiety and depression. You can imagine a person with a neurological insult. There's been a traumatic event. There is even going to be more impacts of those cognitive elements. So anxiety and depression is going to be part and parcel of those patients anyway by default. But along with that, you're going to have complex issues of memory. You know, if the speech is gone, if the swallowing is gone, so you can just sort of imagine the whole twirl they are into, and in doing so, if you avoid the services of a neuropsychologist or a neuropsychiatrist, you have sort of missed out important elements. I think the drawback and the part of the problem and the issue here is that we are so focused on our professions individually that we tend to forget that eventually medical rehab is a multidisciplinary approach. So as a physio, you would tend to spend your half an hour, 40 minutes on exercise therapy and get out of it. However, if you take a step back and think, okay, hold on, you know, this is a neuro patient. Has he had a basic cognitive assessment done? If not, go for it. If those services are not available through a neuropsychologist or a neuropsychiatrist, you can step in. There's a lot of tools, basic tools available, and you get a brief idea saying, okay, you know, the problem here is memory. I will have to make sure that my rehab program focuses more on that. The problem here is executive functioning, and then you can signpost your rehab accordingly. For a simple example, that if the person is more in terms of an executive functioning problem, you want to make sure you straight away start doing elements of rehab which are eventually going to be related to his or her profession rather than waste time on basic elements. Or if you need to step further back, then you start thinking about, okay, the problem is very basic here. The person is not able to understand, not able to process information. So you cannot rush into doing tasks which will eventually be more of a drawback, frustration for both your client and yourself as well. There are various components of cognitive rehab. Unfortunately, beyond the scope to go into details, but just to give you a teaser that once you know those cognitive impairments, you educate about the cognitive strengths and the weaknesses. And this is where you try and find out whether you can match up the internal and the external maps together. Depending on that, you then start developing a skill set for that person. It could be a completely new skill or refining, retuning those existing skills. And with technology nowadays, you're going to use what we call cognitive prosthetics. So softwares like Mind Maze, 3D sort of stuff, V at a very basic level, V games and stuff, and so on and so forth. And eventually, at the back of your mind, you're thinking to improve functional tasks through an element of cognitive rehab. I think one final key message for us as clinicians, whatever element of rehab that you do, you want to make sure and think that will those skills be transferred to the real world. If they're going to be confined to the rehab setting, then I'm sorry, you're not thinking beyond what you should do as a responsible clinician. You want to make sure, put yourself in the person's shoes and make sure that you feel the way you should be. So you want to make sure the person gets back into some form of reality if the injury is very complex and not just confined within those rehab settings. And importantly, you want to make sure you are then sort of following it up. And this is where there's a bit of a gap as well, that a phase of rehab is completed and that's it, there is no further follow-up. So you want to make sure that those effects are persistent with time.
Thank you so much,
I
sir.
think I'm going to end this lot of talking here in terms of cognitive rehab. So I hope I didn't take much of the time and people are still awake and not off to sleep with my presentation.
Thank you so much, sir, for providing us such a knowledge, for giving